Hello, everyone, and welcome to this webinar session organized by WHO and TechNet21. We are recording this session, and we will send you the links to the presentation as well as to the recording after the session. In the meantime, I will let Carolina take the floor, and hope you enjoy this webinar session. Thank you very much. Carolina, the floor is yours.
Hi, everyone. Welcome to the session. I am happy you're here. Please do write your name and where you're connecting from in the chat, and we'll be ready to start. Yes, please do write in the chat so we have a better understanding of who is joining us and from where. Thank you.
In addition, if you have any question, you can ask your questions during the webinar session. I think they will be answered after the session. You can ask your questions in the Q&A section. That would be preferably, but you can also ask questions in the chat room in case you can't find the Q&A section. Thank you.
Welcome, welcome. We are receiving people still connecting, so please write your name and where you're connecting from in the chat. And we're happy you're here. And let's give 1 minute for people to finish connecting and getting ready for a very interesting talk today. Alex, over to you.
Thank you. So welcome to the people who just joined. We have representation from the US, Nairobi. We have Brazil, Ethiopia, Atlanta. People representing UNICEF. People from Bangladesh, CDC. Hi, Jude from Geneva. Lots of people from CDC, Costa Rica. I think we should be able to start now. We have people from Bangladesh, UK, Washington, more people from Brazil, Zimbabwe, Bunji, and Geneva. So I think we can start. Aloysio, the floor is yours.
Okay. Well, good morning or good afternoon, everyone. These virtual platforms are amazing, and we have learned to use them with the pandemic. It's really great to have this group joined, and we are very pleased with the opportunity to presenting this work. I am Aloysio Barros from the International Center of Equity in Health, based in the University of Pelotas, Brazil. We have been doing a lot of work in terms with a focus in health equity, basically using health surveys as a source of data. And our group also works with life cycle epidemiology, and we run currently 4 birth cohorts here in Pelotas. And I'm mentioning this because the idea of decision trees is not a new one, but interestingly, it has been very little used in epidemiology. I was checking back in 2005. I had a PhD student working with nutrition and post-surgery complications, and we wanted to use decision trees to find which were the characteristics of these patients that would give them a high probability of having complications after surgery. And we tried to use decision trees at that time, but given the limitations in terms of computing and limitations in terms of knowledge of how to use these things, we ended up doing sort of a more traditional analysis. So I was very happy when Tiago Melo Santos started working with us a few years ago And he was interested in this kind of approach method. And so we finally were able to put this to work. And we have done a few analyses using this, and the one Tiago is presenting today is using decision trees to find subgroups of children with a high likelihood of not having received any vaccines. We have done a similar thing in terms of intimate partner violence. And I think this is a very interesting and a very sort of useful approach for this type of question. So which are the groups with sort of a high probability or a very low probability of some outcome? So I'll let Tiago to sort of introduce himself and his work, and then present this paper that is, I think, really interesting and relevant. Thank you, Tiago.
Thank you, Aloysio. Thank you, Carolina, for the opportunity. Thank you, everyone, for watching. My name is Thiago Santos. I'm a researcher and a PhD student here at the University of Pelotas and the International Center for Equity and Health. Aloysio has been my advisor from the beginning. It's been a pleasure, Aloysio. And today I want to talk to you about the use of decision trees. I want to talk about this specific study that we did for zero-dose children, but I want to give you a general introduction to the method as well. Nothing very methodological, but give you a way of feeling what are the ins and outs of using this tool in practice. So you can have a general knowledge and later decide if you want to use it in a specific situation. Let me just share my screen here. Okay. Sorry, just a second. Yeah, so our objectives here, first, talking about the decision trees themselves. What are they? When to use them, when not to use them, because this actually is something very important as well, how to interpret the final result, and then a case study where we are going to talk about the paper that you might have read. So first thing, decision trees, the name refers actually to both things, both to the statistical method that we're going to talk about here, but also about these decision-making tools that are not necessarily a very strict model, but rather a way of thinking. So I want to give you two examples. First one, when we're talking about it as a decision-making tool, think about your house and when you're looking at the weather and you are deciding whether you should take an umbrella or not. So first thing, you look at your app, your weather forecast, and you see, is it going to rain? And then if no, you leave without an umbrella. If yes, and then you check it again and think, oh, is it going to be really bad? Is it going to pour? And then you see, no, if it's not going to be that bad of a weather, then you decide, okay, I'm going to leave my house and take an umbrella. If it's really bad, then you think, yes, so no, maybe I should stay home. So this kind of thinking of having binary decisions and separating and deciding, oh, should I do this and that? This is a decision tree. But you can see there is no statistical method behind it. It's just a way of thinking. So when you think about the method, I want you to think that it comes from this idea of deciding different situations based on information that you have. And these variables that can help you. In this case, the idea of, is it going to rain and how bad is it going to be? Now, when we use the decision trees as a statistical method, I want you to think of this. This is one of the examples that Aloysio was talking about when we did the research using decision trees for intimate partner violence. So we had a lot of information about the couple, and we wanted to know which of those informations could be used to identify these high-risk groups. How can we find a specific group of women that have a really high probability of experiencing IPV? So what we did find in this example, first thing, the question was, did the partner have no education? If it was yes, then the probability of having experienced IPV would go really high. We started with a group of 20% prevalence and then went up to 31. And then the tree looked at another question. The women witnessed violence during the childhood from the parents. And if that was, the question was positive, and then that prevalence would go up again to 41%. So when we look at those two questions together, what we did find is this last group here, the one on the bottom right, with a 41% prevalence of IPV, and that group represented 15% of all women. So we kind of narrowed down in a smaller group compared to the whole sample with a really high prevalence of IPV. So this is the idea of finding a risk group. You want to find a small group that has a really high prevalence of the outcome that you're trying to study. So when do you use those decision trees? We did a review of the literature and we found that they were used most in these situations. First thing, for exploratory analysis. I'm starting to think about a new subject. I don't know that much about it. I have a lot of variables. I want to first start to understand any form of patterns. And people use decision trees a lot because they are actually a very simple kind of model. So it can be good for exploratory analysis. Second, it's also used a lot in clinical research for both diagnostics and prognostics, meaning, oh, if I have these specific characteristics of my patient, what can I expect to find? What is the prognosis or the diagnostics that I'm expecting based on those informations? Fourth, is being used to create guidelines. So, for example, during COVID, we saw some research papers talking about, the guideline for receiving someone in healthcare based on the symptoms that they had. So it can be used for that as well. In pharmaceutical, we see a lot of established cutoff points. For example, to try to establish a dosage that is correct for medication. Decision trees can be used for that as well. And last one, the one that we're really interested about, is finding risk groups. So this is the idea of trying to find these specific groups in the population that are different. They are outside of the realm of the typical way that we find of this problem. So it's trying to find this small group that really concentrates the outcome that we're trying to investigate. So a very important thing here to think when you are deciding to use a decision tree or not is whether you are trying to do
Is the sound going for everyone?
I think we lost Thiago.
Yeah, I think he has a problem with his internet.
Okay.
Let's just give him
Yeah, he's
a few minutes. And,
okay, he's back.
okay, good.
And you're on good, Thiago.
Oh, so sorry, something
Okay,
might have.
Now it's working.
Good, great. So I was talking about prediction versus explanation. So when you're doing your research with decision trees, you have to think about these different frameworks. The first one is about prediction. Think of the COVID case. I have a lot of information of someone that is just arriving in a healthcare facility, and I want to make a prediction. What is the most likely outcome? In that way, I do really care about the individual and very specific predictions for each individual person. Versus when I'm talking about explanation, which is the case of zero-dose trees. In our research, we were not really trying to create prediction algorithm that I would look at specific information and say, oh, this child is zero-dose or not zero-dose. Because if I have the child in front of me, I can ask the mother. A very different way is thinking about this explanation. Can you explain the patterns that you're seeing in your sample? And it's more in a community-based way of looking at the problem. So prediction tends to be more individual, explanations more about community. And this is important because it changes the way you're going to evaluate and interpret the decision trees that you're going to use. So here I'm going to be focusing more in the idea of an explanation algorithm, not a prediction one. So what are the advantages of using the decision trees? What are they good for? So first thing, identification of groups with different profiles. They are very good because they are designed to create groups and to divide the sample in different groups. So by design, it can be used for that. It's very good in handling interactions between variables because when you're doing a regression, for example, you have to specify those kind of interactions. And the good thing about decision trees is that they automatically are going to look for those interactions. So it's built in their algorithm. You don't have to pre-specify, which can also be a problem at the same time, because it can start looking interactions that don't exist. So you have to be careful with your sample size. The third thing is that no requirement or price specification of groups should be tested. Think about this. If you're trying to find these risk groups, one thing that you would have to do if you're using a regression analysis, you would have to specify, oh, I want to be this interaction between urban households and also wealth and something about the mother. So you have to pre-specify all those groups that are going to be that you have to look. And it can also be a problem if you do like a lot of groups. You always end up with a problem of groups with small sample size. So making those making information on those groups can be really problematic. And what decision trees do is they automatically like sweep all those possible groups and try to make the best guess automatically without having the necessity of pre-specifying. And the fourth thing is that they're very flexible to work with multiple variables. A lot of times when you're working with a regression analysis, you're trying to streamline and choose the best variables. The thing is, with decision trees, you can use a really like large range of variables because the tree will not use all of those variables. The tree is going to select the ones that have the highest predictive power. So you don't have to worry too much about using that many variables, something that we usually have to be more careful when we are doing a regression analysis. And what to not look for in the decision trees. So things you are not going to find when you're doing that. First thing, there is no causal relationships. Decision trees, they are just trying to find characteristics that can separate those groups. It doesn't mean at all that those characteristics are actually the cause of what we are seeing. Second, about the idea of hierarchical modeling, because a lot of people, when they look at the decision tree, they see the structure that you have in a hierarchy. That does not mean that one variable is more important than the other. It doesn't mean that you are actually doing a hierarchical model. So it's just the way that the information is presented. You're not doing an actual statistical hierarchical modeling. Third thing, risk groups, when they don't exist, a lot of problems, risk groups, they don't exist. So you cannot force and to try to find when you don't see that kind of thing in your problem. Because risk groups, you have to think, is this small group that concentrates a lot of the problem. Sometimes it is very widespread and you can't find this kind of thing. So decision trees is actually a good thing. They will just produce what we call a stump, which is they just don't divide the sample at all. So you just get the sample without any form of groups identified. And fourth, control for confounding variables. If confounding is something that's very important for you, decision trees are not the best ones, because even if you put, for example, let's say wealth is very important for you, and you need to control for that. If you add wealth in your model and is not used by the tree, that information is simply ignored. So you are not controlling for wealth at all when you are using a decision tree. So how does it work in practice? So I want you to look at the bar on top here. Imagine that it is your sample. And it has this kind of light green color, which indicates that you have this mixture of what is your outcome. So let's say 0 those kids, and they are mixed throughout all your sample. So what you want to do is to divide, and what we do is it's called a binary division. So always division in 2 groups. And what you see, what the tree tries to do is when it separates those 2 groups, it tries to leave one group that has a higher concentration of 0 dose children and another group with a lower concentration. So the group on the left here, you can see is kind of a darker green. So it concentrated. So now we have more 0 dose children in this group, while the other group is kind of gray. It means that you have a lower prevalence of 0 dose. So what the tree will try to do is a recursive process. So it's going to continue doing this division. You can see that it goes down again, it divides, it divides, and divides. So in the end, what you end up with is a lot of different groups, and some of them are supposed to have a really high concentration of 0 dose children, which is what we want when we're trying to find a risk group. So some important things. Divisions are permanent. So when the tree decides to do one division, so I'm divided based on wealth. After that first division is already done, it doesn't try to do that again. So it will continue the division for the rest of the tree. Second thing, not all groups continue to be subdivided. There are a lot of specifications that you can do, that can select. You see that sometimes some subgroups are going to be divided again, but others are not going to be divided. So the tree does not continue to subdivide eternally. And last, each individual in your sample, so each child in the end is going to be assigned of one of those final groups. So what you have is your original sample now divided into groups 1, 2, 3, 4, and 5. And some of those groups are going to have a really low prevalence of 0 dose, and some of them are going to have a really high prevalence. And what is high here, of course, depends of the original prevalence of the outcome that you're studying. In terms of method, the one that is most commonly used is called CART, classification and regression trees. The term classification is used when you have a binary outcome. Things, for example, if you're doing a research that is about, you're trying to find DPT-3 children versus children that are not DPT-3. So you're going to do a classification problem. Now, let's say if you're not trying to study that specific outcome, let's say that you're trying to study the average number of DPT doses. So what you're doing is a regression tree. So what the tree is going to try to find is groups that have a very different number of average number of DPT doses. And there are many methods for use that people use for decision trees, but there are two that are kind of important in epidemiological research. CART, which is the one that is mostly used in the literature. You see most of the papers published use CART. And what it does is this process that I described. It does the cutoff points and try to separate subgroups with different patterns. And it uses a measure of impurity. Impurity is just that idea of not mixing 0 dose children with non-0 dose children. So you want to have groups where all the 0 dose children are isolated in the group and all non-0 dose are isolated in other groups. And C-tree is a more modern technique that uses a more formal statistical test, like a chi-square test. So this C-tree I'm saying is here because it's important, for example, if you have really small sample sizes. So CART can be really problematic and give you some type 1 errors, while C-tree tends to be better when you have really small sample sizes. Finally, some things that you should pay close attention if you are using a decision tree. First one, be careful when you have an outcome that is too rare or too common. Think about, for example, 0 dose children. We have a really, thankfully, relatively low prevalence. When I say low here, I'm talking about 10, 15, 5%. When I say high, I'm talking about 85, 9, 95. Because in this kind of algorithm, classification algorithms, you have a problem with what we call unbalanced sample. And balanced sample is when you have 50-50. So you have an outcome that 50% of the children are positive and 50% are negative. This is called balanced, and usually the tree performs better in this kind of situations. When you have the situation of outcomes that are rare, you have to do some specifications of how you produce the tree in order to take into account this rarity, or the tree is just going to ignore that information, which is the case that we have to do for this paper. Second one, if you are using CART, be careful with small sample sizes because CART does not take into account the sample size at all. So what you end up doing is having these really small subgroups where you are just overfitting your data. And third, about variables with many categories. This is a problem that's been known in the literature for quite a while, that CART, it tends to choose variables that have a lot of categories. So think about, for example, we had a problem when we were doing this paper. We were first thinking about using ethnical groups, but a lot of countries, they have like a really large number of ethnical groups. So in the end, we saw that it was just overfitting because you had all of those groups. The tree could do like a lot of combinations between them, which were not actually very significant, but more in terms of overfitting the data. So be careful of not using variables that have like a lot of categories, something like above 8, 9, or 10. Now, about the paper itself, we were doing this research trying to identify those high-risk groups for zero-dose trees. We used data from DHS and MIX. We had 92 low and middle-income countries. We were trying to do the identification of high-risk groups of zero-dose children. Zero-dose here was defined in this paper as not having received any doses of the BCG, DPT, measles, and polio vaccines. And we did a review of the literature, and we selected 17 indicators. Most of them based on what was already in the literature, and others we added because of our own theories about the subject. And we used CART. We actually tried C3 as well, but in the end we decided to use CART. So this is the main result that we get in the paper. This is our larger tree. So imagine that this is a tree created with all the countries, the 92 countries combined. So it's a really large sample size here. And it was very interesting when we saw the result, because we had a lot of information of the mother, the household, wealth, and all the inequity analysis, all the indicators that we usually use. But the tree decided to select three informations that are related to maternal care. So here on the top, you can see that you have the group really on top. Our original prevalence was 8% of zero dose among those children. And in that group of the 92 countries together, the first variable that the tree chose was whether the mother had received any doses of the tetanus vaccine before or during that pregnancy. And if yes, the tree would put the child on the group in the bottom left, which is group 1. That group has a prevalence of 6%. It has 90% of the children. So you can imagine that this is a really large group. So most of the children in the sample would end up in this group, because most mothers would have at least one dose of the tetanus vaccine. So this is the group with the lowest prevalence of zero dose. Now, if the mother did not receive any doses of the tetanus vaccine, the child was assigned to the second group from top to bottom. That group has a prevalence of 25%. So you can see the shift. We started with a group of 80% prevalence of zero dose, and now we are at 25%. And in this specific group, the tree checked again for another information. This one was whether the mother had at least one antenatal care visit for that specific pregnancy. And if she had at least one visit, the child was assigned to group 2. That group has the prevalence of 11% of zero dose. But if the mother, now imagine we're talking about the mother that did not have any dose of the tetanus vaccine and also did not have any antenatal care visits. And in that situation, the child was assigned to the third group from top to bottom. And in that group, now we have a prevalence of 39% of zero dose. So I want you to imagine that what the tree is doing here is creating smaller and smaller groups, but having a really larger concentration, like the concentration and the prevalence of zero dose is increasing as we go from one group to another. Each variable that is selected here is increasing this prevalence, is concentrating the zero dose children in that group. And in that final group, the tree chose whether the child was born in a health facility or not. If she was born in a health facility, the child would go to group 3, which has a prevalence of 23%. And if not, which is the case what we call the triple exposed child. So imagine that we are talking about a child whose mother did not receive any dose of the tetanus vaccine, did not have any antenatal care visits, and the child was not born in a health facility. So we're talking about a really bad situation for this child. If the child was in this situation, the child was assigned to a group that had a prevalence of zero dose of 42%, which is a really high prevalence when you're talking about zero dose, which is a rare kind of outcome. So in the end, our whole sample of 92 countries, all the children were divided into 4 groups: group 1, 2, 3, and 4. And when you go to the left, from the left to the right, what you see is that the prevalence is increasing. Group 1 has a prevalence of 6%, and then 11%, and then 23%, and then 42%, which is a really high prevalence in that group. And what you're also going to see, I want you to look at group 4 now, you see that this group is really small. It only has 4% of all children in the original sample. And it contains 24% of all zero-dose children. So what does that mean for us? It means that when we use this algorithm, what it helped us was to find one group that is really small, just 4% of all children, but that group contains 24% of all the zero-dose children that we had in our original sample. So let's say that magically we can somehow find all those children and solve the problem. What we're saying that is that those 4% of all the children, they carry 25 or 24% of the problem. So we could solve like 1 in every 4 zero-dose children problem if we can find that smaller group of only 4% of the children. And the thing that is really interesting here is that not only we can find these smaller groups where we can target and tailor interventions, but we are also finding all these variables that together. So the result is very consistent and simple. In the end, what we're saying is that we're talking about a child and a family, actually, a structure that is being left out by a lot of different health services, not only vaccination. Even before the child was born, we have this mother not being able to have been vaccinated herself, not having any form of antenatal care, and not being able to deliver in a health facility. What we also did in this paper was we did profiles for each separate country, and we created a tree for each one of the 92 countries. And what ended up happening was that for most countries, we couldn't create a tree. We had what I call the stump. So where the tree simply wasn't able to divide the sample. But for 25 countries, we could find actually those trees. And what we saw was that when we look at the different trees of individual countries, the variables that were the most common among all of those 25 countries were precisely the ones that we got from the general tree. So the variable that was most selected by those trees was the number of antenatal care visits. The second one was the place of delivery. And the third one was the tetanus vaccine of the mother, together with Welf quintiles. And that tells you as well that, of course, we had India here. In India, of course, because of the sample size, really, and of the number of children that is taken into account here as well, it really can shift the result. But even when we look at the different, the individual trees, we also see the importance of all these tree variables and the connection with other health services to indicate that this, the group with a higher risk of not being vaccinated is the one being left out by also all these other health services. Just to show you a couple of examples, here we have the case for Chad in 2013. This is the profile that we created for each country. So we have the map, we have information of some of the most relevant variables that we saw for the country, but here we have the decision tree. And in the case of Chad, we had 2 variables that were selected. The first one was, again, the number of tetanus, the doses of tetanus vaccine that the mother would have received. It was the first question again. And the second one, in this case, was religion. Religion actually was featured in 4 countries. And in this case, the group that was selected was Muslim households. So Muslim households would have a larger prevalence of 0 dose, because if you look at this in the bottom, the second and the third group, the difference when we separate Muslim households from non-Muslim households here, the non-Muslim households, the children from those households had a 12% prevalence of 0 dose, while those from Muslim households, it's a 51%, so it's a huge difference in terms of the prevalence here. Let me remind you that, again, decision trees, they don't say anything about causal inference, so we're not saying that this is caused by religion. We are just saying that it can be we can find these children in Muslim households in Chad. Another example here is the case for Kenya. This is a stump. So this is one of the examples where the tree simply did not form. In the end, the tree that we have is just this box that is the original sample, because we couldn't divide it into smaller groups. And there are a lot of reasons for this to happen. In the specific case of Kenya, it's very likely because of the really small prevalence of 0 dose. We only have 2% of the children being 0 dose, thankfully. And this can really hinder the ability of the tree to really find, because the tree has to find a higher prevalence. So it's really hard to really nail down a country, in a country like this, a really specific group. When you're talking about this, you're talking about children that are very likely spread out, and you don't have really a group, a well-defined group that could be selected for the three. Of course, there is the possibility that just our variables were not the ones important for this specific case. Perhaps the case in Kenya, you have other variables that could have been important, and we could have found those smaller groups, but we could not find it in this specific paper. So last thing, where can you create a decision tree? If you want to start doing it, I recommend you can do it in R, Stata. There are other programs that can do that as well, but in R, you can use the RPart and the PartyKit packages, and Stata, you can use the CR trees package. I've tried both of them, the three of them actually, and they are very good. So if you want to try, I recommend using those two. So, muito obrigado, as we say here in Brazil. Thank you very much. If you have any questions, suggestions, we are open to those. Aloysio, I think with you.
Yeah. I would like to make a few comments before we open the floor to questions. Well, thank you, Thiago, for your presentation. I think it was very, very clear, very comprehensive. What I wanted to highlight in terms of the method itself is that I really like these decision trees. First, because they are very intuitive. It's easy for people to look at the tree and understand what's going on and which characteristics are defining low-risk groups, high-risk groups. They require very little assumptions. So you just throw a bunch of variables in there, and the sort of algorithm will take care of them and choose the best selection of variables and groups to find your different low and high risk groups. I think Thiago made it very clear that this is not a causal model, and probably it will choose, given the availability of variables, the ones that are sort of more proximal, closer to the outcome you are studying. It's less likely to choose sort of distal or contextual variables and so on. So because they usually the more proximal variables will be the ones that will define sort of more directly who's high risk, who's low risk. So I think this is something to bear in mind, and that leads to one, I think, very important comment. The selection of variables that go into the model, that go into the algorithm, is absolutely key. So the selection of variables has to be very well thought in a way that the variables you put into the model can actually answer your question. Because for instance, if in a country level analysis like this, if you add subnational regions, for instance, they are very likely to show up because they end up sort of including a series of characteristics of the children in terms of being remote or being poor or being in an area with an ethnicity that is mobile and so on. So you end up with a geographical marker and you lose sort of individual characteristics. So the selection of variables that goes into the model is key to be sort of in sync with your question. And finally, I would just like to highlight that despite these trees being very useful, in the sort of general model that Thiago showed, 24% of the zero-dose children were in group 4, so the high-risk group. But in the low-risk group, we actually have nearly 3/4 of the children that are zero-dose. So the sort of most of the zero-dose children are actually sort of dispersed around this much bigger group that is low risk. So you focus on the high risk group, you're able to sort of deal with a quarter of the zero-dose children. But 67% of them are actually in the low risk group. So it helps identifying some groups of high risk, but in this case specifically, it won't help you reach all of the zero-dose children. So anyway, I think it's interesting. It has its advantages. It helps understand what's going on, but it's not a solution for everything. So that's it. Thank you.
Thank you so much, the team. And I think the floor is open for questions. Alex, I don't know if you have questions in the Q&A.
Yes, there are like 2 questions or comments. Let's start with the question from Nancy Fullman. You mentioned India having a major effect, which is not surprising given how large household surveys are. How does the inclusion or exclusion of other countries affect decision tree results based on the currently included 17 indicators, especially if those countries have higher ZD burdens?
That's a very good question, Nancy. We did a lot of different experimentations with the method in order to identify this. First thing, I think India is extremely important in the results that we got here. If you look at the tree that we found for India, it has pretty much the same structure as the general tree. I also tested, I don't remember right now precisely what we got without India, but definitely this result is the result of some specific countries that gather those, because the 2 things that usually are really important here is, one, not only the sample size, but also the prevalence. The 2 things together in their combination. So countries that have a smaller sample size, but have a higher prevalence, sometimes they won't have that much of an effect here, because one of the things that we did in this paper, we also changed the sampling weights. We weighted those countries that had a higher population of children more than the countries that had a really small, because in our research we have some really small countries and they could have like they could really change and skew the results. So in the end, it depends a lot of the choice that we're trying to make. So since we wanted to do all of this together and we had a really large sample of countries, 92, we decided to take into account the population of children. But if you look at the individual trees that we see in all of the countries, we see those variables. What we usually have is a different structure of the tree. So, for example, tetanus was the first one. Sometimes it is the second one. The being born in a health facility more likely doesn't appear. But in the end, like the major variables, they tend to repeat themselves, even in the countries that have different trees. So I would say that yes, it definitely depends on the size of the country, the sample size, and the zero-dose prevalence. But in this specific case, and I've tested decision trees for other outcomes, the situation is completely different. But for this one, things tend to be more or less consistent. We tend to see the same variables appearing again and again. So I would say that our results are not that dependent. I would say that the third division there of health, being born in a health facility, this one is the more dependent. Depending on how we specify the tree, it would disappear or appear. So, but the first 2 ones, the antenatal care and the tetanus data, tend to be very consistent in the results for both national trees and the combined sample.
Thank you, Thiago.
Thank you. Can I ask a follow-up question to that?
Go ahead.
Maybe the opposite, Thiago. Which countries were those that you had not a stump, but you had a tree that had something that surprised you, that it was not the usual maternal variables? Over.
Yeah, I wouldn't say they were really surprising. The variables that were selected were usually wealth, area of residence, which are things that we are tired of knowing that they can really affect vaccination. So I wouldn't say that there were really that many surprises. The thing that personally really caught my eye, and also we try to follow up in another paper, is the religion. Because religion, it appeared in 4 different countries, and usually the 3 would select Muslim households, sometimes combined with folk households and other groups, but usually the higher risk group would be the Muslim one. We are doing some research about this right now. And I would say that that's the thing that caught my eye, was really more surprising, because the other variables tend to be either about healthcare or your basic wealth, modern education, and area of residence. Those were the ones most selected by the different countries.
Thank you. Alex, please.
Thank you. There's a question from Niklas Danielsson. So first a comment. You find very strong associations between a number of indicators of mother's health care use and socioeconomic status on one side and vaccination status of her child on the other side. For example, one of 4 zero-dose children have a mother who didn't use any A and C, didn't get tetanus vaccination, and didn't deliver in a health facility. Question: are you aware of empirical findings of studies that found causality? In other words, if your health system were to make sure that the proportion of pregnant women who use ANC, receive TT, and deliver in a facility increased, for example, through the use of conditional vouchers, CCT, for these services, would it then follow that their children would be more likely to be vaccinated given that other factors remain the same? Between brackets, education, literacy, wealth, etc. Does the contact with health facilities during pregnancy determine that the child will be vaccinated if tested in an intervention trial? That's a long question. Tiago.
Okay.
For Aloisio, this one.
Oh, yes, Aloisio. Okay.
Let me try to answer to that. There is also another question in the chat that relates to sort of variables related to health service versus sort of socioeconomic markers like wealth and maternal education and so on. So I think the key thing here again is that this model is not causal at all. So sort of finding that receiving tetanus vaccine or having antenatal care and so on are markers for children that are highly likely to be zero dose. That doesn't mean that acting on those points will change anything. These are just markers of high-risk groups. If you think in terms of a causal chain, probably you have like wealth and education are your sort of distal determinants that sort of trickle through the chain of causality, and it gets to the more proximal determinants like access to health services. So I think what this result is showing is that those children of mothers who have very limited access to health services are those that are most highly likely to be zero dose. What you have to fix is the accessibility of services that the solution for that may be different for different contexts. Maybe lack of facilities, maybe lack of resources from the family to go to the facility. It can be a lot of things. But for me, the main interpretation of these results is that vaccination and access to sort of the health services that are offering pregnancy and maternity care are closely linked. So I think in some places, vaccination services or programs are sort of very vertical and isolated from the rest. And for me, this is saying that, well, you need to partner to offer sort of integrated services that include all of the care that a mother needs and then her children will need.
Thank you very much. There's Solange Wegan, who actually asked 3-4 questions and is raising her hand. Carolina, can I open the mics, or do you prefer that we read the questions?
No, yes, please pass that to Solange.
Okay, Solange, I'm giving you the possibility to speak. You can unmute yourself.
And introduce yourself, Solange, please.
Good afternoon, everybody, or good evening. I am Solange Wega. I'm connecting from the West region from Cameroon. I'm a statistician and actually an assistant lecturer at the University of Chang. So I was very interested by the presentation of Thiago, who used the decision tree approach to identify community where there is a high risk of zero dose. And this question of zero dose is very interested. Sorry, because I missed the important part of your presentation, that you see the case study. So my question was to know how or what are the expected prevalence that you need to observe before using the decision tree approach? And finally, what are the strategies that you use to choose a variable that you include in the model? Because I heard about it, but I didn't understand what did you use as the criteria, as the tip to identify those variables. Then my final question is this decision tree approach the same as the forest tree approach? Or is it the same method, the same style of analysis than the multiple component analysis that we use to identify cluster? So what are the link between these methods? Thank you.
Thank you, Solange. Okay, let me try to break it down, those questions. First thing about the variable selection, what we did was we reviewed the literature for zero dose. And since decision trees can deal with a lot of variables, what we try to do is like, let's try to find all the variables that were tested, even if they were not significant. The paper did not present a significant results, and then we can do a selection and do some trials of whether to choose those variables or not. So we had this really long list of all possible variables. We also reviewed the questionnaires for mix and VHS, because we tried to select those that were available on both surveys, because they have some specifications that tend to change from one to another. And what we did in the end was, after carefully reviewing each one of those, we did some individual tests for some countries in order to avoid testing with the whole sample. And in those tests, we saw some problems that would arise here. For example, with ethnic groups or subnational regions. When you choose those kind of variables that have a lot of different categories. In some countries, you have like more than 20 ethnic groups in the sample. That can be really problematic. Why is it a problem for us? Imagine that when you have this, and sometimes the sample of zero dose children is small, you're talking about maybe 50, sometimes 70 children. What ends up happening is that that variable of ethnic group, subnational region, it kind of can identify specific children. So it isn't talking about precisely of a pattern of that region or that ethnic group. You're talking about 3 or 4 or maybe 2 children who belong to that ethnic group. So what the tree will tend to do is select that variable and say, oh, children who belong to this specific region are at a really high group risk. And when you look at that group, you see that it's a really small group. So it isn't actually making an inference about that. What it's actually doing is overfitting. So it's just modeling noise and not precisely a pattern a more consistent pattern that you see. So that's one of the very important things. And one of the things that you can do when you're trying to choose variables like that is you can try to recategorize. It's something that we did, I think it was occupation of the mother. We combined a lot of different groups in order to have a smaller number of groups. And also you have to think in your selection here about the question you are trying to answer. Sometimes if you want to create a decision tree that is something to be more actionable, so I want to find this very specific list of variables that can be used, for example, for someone in the country, the health ministry, and is an information that they have quick access and they can use to identify those children. So you must select variables according to that specific research question, which is not the case here. We were trying to find all these groups based on what we can in the literature. So in that scenario, you can be more open in terms of your selection, but you also at the same time have to be careful because of the specifications of the use of decision trees, with this thing, for example, of not having really a really large number of categories in a variable. So
thank you so much.
That's the first one. Sorry?
There are some other questions related to, is the decision tree approach the same as the multiple component analysis? Because I know that from there you can do cluster, maybe the group of variables that where individuals look the same, have the same profile. So is it the same as those methods of multidimensional analysis?
They do have some similarities. I'm not an expert in those, so I'm going to say based just on
because I know that in the data set, for example.
Yes, go ahead.
Yes, I was saying, is it the same as the multiple component analysis method? Because when you have several variables with multiple categories, you can look for profile, you can look for subgroup of people who have the same profile. So is it the same? Does it have the same methodology approach?
Aloysio, I don't know if you know that method very well. I've read about it. And you also asked about forest trees. Forest trees is one that I know more about. They all belong to a category, a larger category of machine learning algorithms. And although they can be similar, they are different methods, each one with their specification. So that one you mentioned, I can't say a lot about it. I will talk about forest trees specifically, which is the one that I have more knowledge about. They belong to, they are very similar, but they are different methods. They don't behave the same way. Forest trees, they actually use decision trees inside. So the name forest is that actually it has a lot of different trees at the same time when they are creating the model. And this is one of the things that drives us to use decision trees and not forest trees, for example. Forests, they tend to be more precise, they tend to identify better the groups. But the problem is when you're using those machine learning algorithms, what you end up doing is that you create this black box, this really complex model that is actually capable of doing really good predictions, for example, but you can't understand what they're doing. Because the forest is this idea that it has a lot of different trees, and it can get really complex really quickly. So in the end, what you end up is a good prediction that you can't understand the patterns and anything that is going to research. So the reason why we looked at other methods in the beginning when we were choosing this paper, but the reason why we chose decision trees is that from all those methods, decision trees tend to be the simpler ones. They tend to produce the result that is really comprehensible, and that, for example, you can show and print the decision tree like a paper, like, oh, okay, so this is what, imagine I was talking in the beginning about the decision tree, not as a statistical method, but as a way of thinking of, oh, if I do this, this is going to happen. So the decision trees itself tend to be, I would say, they're not as good for predictions. They tend to be more of a coarse way of doing this kind of analysis, but they tend to be easier for explanation. So it can be more actionable in the end, which was one of the things that we wanted with this paper. Louise,
okay,
you want to add?
thank you. So can the method be replicable if you are dealing with maybe the percentages of coverage, the coverage? Can you use the same method where you are dealing with coverage?
Yes. The thing is, you can try, because there is, this is very technical. When you're using CART specifically, you have one parameter that's called the complexity parameter. It's called CP. If you adjust that CP, you can actually work with samples that have a lower prevalence. So in this paper, we had to do this. We used a CP and you can use that CP and another thing, which is called misclassification error. The weight that you use for that, those two are very specific parameters that I don't think I need to expect. I'm not going to specify too much here, but those parameters can be adjusted in order to take into account the reality of you using a much smaller prevalence. So in this scenario here, we had an 8%, which is a low prevalence. If you go to 2, and then you really have to like pump up those parameters, which is something that I usually not very comfortable with. It tends to be very like arbitrary, and you're not very sure, oh, am I actually finding a pattern, or am I just trying to force the analysis to give me a result? So usually I try to avoid that. But I would say like usually you want to be around 50%. But if you are working with something around 10% is still fine. If in my experience, this is not based on actual science, the two below 5%, you must be really careful. You tend to not be able to generate results. And above 95 as well. You have to imagine that it is kind of a mirror from 50%. So really high and really low prevalence tend to be really bad.
Thank you very much, Tiago. Very interesting presentation. Thank you.
Thank you, Tiago. Carolina, it's past 5. Shall we take a last question, or can we wrap up?
I think we need to wrap up, but I see questions in the chat and questions in the Q&A. So Dimitri, Edson, Patty, and Palemfo, I think you had questions. So we'll try to reply to them, collecting them from what's written and send them when we share the presentation. Thank you so much to colleagues in Pelotas, and I hope you all read the paper now with more understanding of what it is. And please do send questions. If you have, email me with any questions, and we'll have the colleagues try to reply to them. Thank you so much, everyone, for your participation and for your time. Thank you, Tiago. Thank you, Alucio.
Thank you very much.
Thank you, everyone. I will send you the questions, Carolina. Thank you.
Thank
Have
you.
a nice day, evening, everybody. Bye.
Bye-bye.
Happy Tuesday,
Bye.
happy summer, happy winter, depending on where you are.
Bye.
Bye.